For the Young at Heart is sponsored by Duville Life and Wellness Community, a commitment to care, a legacy of compassion. This is Duville.
Hello, welcome to For the Young at Heart. My name is Lucille Jerome, and on today's program we're going to be taking a look at an alternative healthcare program for seniors called P.A.C.E. I have two guests with me today. Leanna Moran, who's a licensed clinical social worker and the site director for the new Summit building in Lowell, Massachusetts. And we also have Dr. Sean Berkowitz, who is the staff physician, and he's also on the faculty of University of Massachusetts Medical Center in Worcester, Massachusetts. So thank you for coming today.
Thank you.
Okay, this is a heavy-duty subject, and it looks like it might be the wave of the future. So maybe we could begin with, what does P.A.C.E. stand for?
I'll start and you can fill in.
Sure.
P.A.C.E. stands for Program of All-Inclusive Care for the Elderly. It's a certified Medicare and Medicaid program. It wasn't always that way when the first P.A.C.E. program started, but now it is.
Okay.
There's about 115 P.A.C.E. programs across the country. I think that the background of P.A.C.E. is pretty interesting. So P.A.C.E. started back in the 1970s in the San Francisco Bay Area. Yes. So out in San Francisco, at the time, they were experiencing an influx of immigrants from various nations, the Philippines, the Southeast Asia area, Italy. And within all these cultural groups, it wasn't appropriate and acceptable in their minds to place their loved ones in nursing homes.
That's right.
As they got older.
That's right.
And at the time, you know, they had just brought their family to the States. Both the mother and the father in these families were finding they had to work to make ends meet, but at the same time, they had to care for their aging parent. So a couple of community physicians saw this as an opportunity and said, hey, what if we had a day center where our parents could be during the day, but at the same time we'll provide some medical care there as well to kind of do it all in one place, a one-stop shop. And the name of their program was Unlock. And that was the first P.A.C.E. program.
Okay.
And then down the line, you know, it became recognized as a model for the Centers for Medicare and Medicaid.
All right then.
Yeah.
So it went, I didn't realize it started back in the 1970s.
Yes.
Okay. So that's the initial background, and from there it's expanded.
Yes.
You mentioned how many are functioning right now in this country. How many are there in Massachusetts? Do we have a general
I believe
number?
6.
6 or 8 in Massachusetts.
Yep.
So it's expanding across the country.
Yes. And we're lucky to live in a state where P.A.C.E. is offered because it's really, we are regulated as a P.A.C.E. program by CMS, by Medicare, and by the state. So the state has to opt into offering the P.A.C.E. program. So I always like to remind folks the fact that we live in Massachusetts makes us fortunate to have this option for our seniors.
Okay. So we've got a little bit now about the philosophy of the background and the motivation for why it started. Very noble, very noble, very insightful.
Yes.
Okay, and they were observant. So what does P.A.C.E. offer? It's all-inclusive. You're telling me it's all-inclusive. What do you mean by all-inclusive? Because we have an audience out there who's going to want to know this.
Right.
Oh, absolutely. So one of the things that we're aware of is that in just a few short years, about a quarter of the U.S. population is going to be over 65. Now, many of those will remain healthy in the community for many years, but some of them are going to need more services. Many of them are having difficulty maintaining their independence in their home. And you know, nursing homes have a valuable purpose for people who really need a lot of support and care, but many people don't want to live in a nursing home. And so what P.A.C.E. offers is an opportunity to continue to live at home with the same services that a nursing home might be able to offer, including physician services, nursing services, social work, physical and occupational therapy, nutrition and dietary, and even activities. So for the day center, we have an opportunity to socialize and engage with other peers. So the nice thing for me as a geriatrician is that I feel like I have a wide range of support from other disciplines. And I feel like everyone works together very well to really look at the person and make the best care plan possible that's very individualized for that person, including their medical care, their social needs, their home care needs, if they need physical or occupational therapy, speech therapy, looking at their dietary needs and how we can best meet those. And everyone works together to give them the best quality of life possible.
So you have a functioning team.
We have an active functioning team with many professionals across the disciplines.
So do you meet frequently? There's an assessment process. Does everyone have input into that assessment?
Indeed.
Yeah, we have, the whole team has input into the assessment. And then from there on forward, once someone enrolls into our program, that whole team is kind of watching over them. So the team actually meets every single day, Monday through Friday.
Okay.
We start our day meeting as a team. And all decisions that need to be made for our participants, big and small, get discussed as a team. And that's really kind of the magic of PACE, how
Okay.
nothing falls through the cracks because
Okay.
we're all working together every day.
Okay.
And the nice thing is that everyone on the team is trained, educated in care for older adults. We have geriatricians who are had extra training in medical residency and fellowship
Right.
in caring for older adults, and geriatric social workers. The rehab therapists are trained in working with older adults, and that's important because there's
Yes.
particular syndromes and diagnoses, medication problems that are specific to older adults, and so having that specialized knowledge among the team is really important. And helps us keep them out of the ER and out of the hospital and healthy in their own homes.
I can see a market for a growing population of specialists because I remember, I'm old enough to remember when not too many people wanted to work with senior citizens back in the 60s and 70s. All right,
Yeah.
there wasn't a real specialty back, you know.
This is one of my passions, is
Yes.
helping students
Yes.
to engage and interact with
Yes.
older adults.
Yeah.
And we find that students who have that experience are much more likely to want to do it in the future,
Yes.
whether they're social work students or medical students, nursing students, therapy students. We have to give them that exposure, and then they realize it's actually enjoyable
Yes.
and something that they might choose to do.
Yeah, it is. It is enjoyable. It is, and the passion shows through.
Thank you.
From the mentors, the passion will always show through, and enable a student, an intern, a resident to want to at least try it.
Absolutely.
Yes,
Right.
yes, yeah, good. So that's good news. Thank you. How does maybe we could run through maybe a pretend case about someone enrolling and how this then proceeds through your system?
Absolutely.
That might be a good way to start.
Sure.
So just make somebody up.
Okay.
Yeah, so a very classic patient might be someone who's 75, has some medical problems, breathing problems, obstructive pulmonary disease. You know, maybe they were a smoker in the past and they're having some trouble breathing. They might have some heart failure problems, maybe some diabetes. And so they would come to our program seeking care. We'd look at their functionality. Someone needs to be nursing home certifiable, meaning that they have the ability or appropriateness to live in a nursing home if it was
Okay.
deemed necessary.
Okay.
So generally what that means is they need some help in the home. You know, given the medical problems, many people need a little help. It's more difficult to clean your house and do all the
Right.
things you need to do, or even to sometimes take care of yourself as you might have arthritis or other issues. So once they come to our program, we have the entire team do an assessment. We get to interview and talk with them. They get to learn about us, we get to learn about them. And then afterwards, the team sits down and says, is this someone that we can help? Is this someone that we can maintain safely in their own home? And if the answer is yes, we do accept them into the program.
Okay. All right then. And so then the families are involved with this. Do you help someone if they don't have a healthcare proxy in place? You know, that legal paperwork stuff
Yeah.
that gets in the way sometimes if it's not available?
Right.
Yeah?
You know,
Okay.
family members are key really to the success of
Okay.
PACE. So from the beginning, even if it's, you know, the person is just investigating PACE, maybe talking to an outreach worker that we have out in the community, they'd start to work with the caregivers, work with the family members, because it's a partnership not just with our participants, as we call
Right,
them, not
right.
patients, participants,
Okay,
but with their families. We're all in this together to try to help them stay in their own home.
Right.
So when you're talking about team, you're talking about the resident, the
Participant
participant
and their family.
and the families.
Yeah.
Absolutely.
Right,
And from our
right.
model, the participant is really in the middle of the care
Right.
model.
Right.
You know, everything stems from them. It's their goals and their desires that drive the care plan and the team. What it is that you want to do. If you want to be able to walk again, we'll work with you to give you more therapy to try to walk again if that's possible.
Okay.
One of the things we like to say is that we share the care. You know, we look for family and participant support along with us, because we can't do it alone, and you might not be able to do it alone, but maybe we
Right.
can do it together. And I want to put out there too, so even people who don't have family in the area or family that's available to help them, we want to be there for them as well, and we'll try to arrange for more home services when necessary, but it's always best to have the family involved. That's always
Sure.
key.
Sure. Well, there are long-distance caregivers, I mean,
Right.
working in the system, but that would be very difficult because you're all-inclusive. You really have the wherewithal to be able to provide the services rather than bringing someone in from another state, don't you? I mean, it seems that way to
Oh,
me.
absolutely. And Liana can talk more about this, but we do everything in terms of the needs for the participants. So transport to medical appointments, as well as the day center. And
Okay.
as much as possible, we try to have everything take place at the day center. So for their medical needs, they might see me as the physician or one of my partners. The therapy needs for rehab, social worker to meet with them if they're having some depression issues or anxiety issues, particularly if there's a loss of a spouse or some crisis in the family that needs to be processed. And we try to do as much as we can in-house. We do have home health aides that might go to the home, or other services that might happen, such as Meals on Wheels or other interventions that we can do to assist them in the home environment.
Sure. For your participants who might not like Meals on Wheels, you encourage, because some don't,
Right.
do you encourage families to make the favorite meals so that, like if they like, roast chicken or something, they can put it in the microwave themselves, things like that?
Oh, absolutely, yeah.
Okay.
We have another option as well, another vendor that provides meals. So
Okay.
we've been looking for other meals options. And then when they're at our adult day health center, they would have a meal with us.
Right, right. Now, your adult center, are you open 7 days a week or 5 days or 7?
5 days a week.
Okay.
Yeah,
Okay.
Monday through Friday.
Okay. And the transportation would be from the home to your center?
Yes. Yep.
Okay. And you're on the grounds at Duval Life and Wellness Community?
We are.
Yes,
Yep.
okay.
We're in the new building way in the back of the campus, along the woods.
Okay.
I feel like we have the best view on the campus. It's all wildlife back there. It's beautiful.
Oh, I remember the wildlife before we had any of the other buildings. There were
Yeah.
deer and turkeys
Oh,
and
yeah.
pheasants.
A lot
No
of birds now
Birds,
this time of year.
yeah.
No one informed the turkeys that we put up our building, so they still have a highway through the parking lot.
I'm sure they do. I'm sure they do.
But I do want to say that we're really excited to be on the Duval campus. It's a partnership with Fallon Health, which is one of our products is Summit Elder Care, which is this
Okay.
PACE program, and it's a great partnership. And our philosophies of Summit Elder Care and Fallon match up very well with Duval, so it's been a great partnership.
Yeah. Good, good. Glad to hear that. Glad to hear that. What about dental care, eye care?
Yes, yeah. So just to back up a little bit, and this
Okay.
will kind of help fill in some of the blanks, Lucille,
Good.
because PACE can be confusing, especially if we're not sitting at the program right now where I could
Okay.
show you all the rooms and all the
Okay.
disciplines.
Oh.
But PACE is like a four-legged stool. So we're their insurance. When they join our
right.
program, we become their insurance. And we're going to cover all of the services that they would normally receive, say, through Medicare or Medicaid.
Right.
So that includes dental.
Okay.
And all of the services are going to be provided through that interdisciplinary team. So that team is deciding what we think the participant needs along with what they think they need.
Right.
So that would include dental, all their medications, all their durable medical equipment, so things that they need in their home to be safe, and then all the medical care that you would normally get from insurance.
As well as eyeglasses,
Right.
hearing aids, dentures, anything that
Okay.
the team feels is appropriate to give them the best quality of life possible.
Okay.
And no copays for anything.
No copays.
We cover the complete cost for anything that the team decides. And the team are really the people who are taking care of you, so they know you really well.
Right.
And we work together to make those decisions, what's appropriate and what's needed.
Okay. Do they don't keep their own physician if they've had one in the community, or can they?
So that's a good question, and that's one of the major reasons a lot of people are a little bit leery about switching to P.A.C.E. What we find is that most people, after they switch, and we tell them, like, you're welcome to continue to visit your physician. We'll pay for a couple visits a year to check in with them to make sure we're on the same page.
Right.
And after people join, even though they might have loved their previous physician,
Right.
they're very happy with the P.A.C.E. program. They're happy with the providers, and we have good communication with their previous provider beforehand to make sure we understand and transfer services appropriately. And honestly, after the first month, I haven't had anyone who's wanted to go back to their previous physician. They're very happy with the program and the services we offer.
Yeah. There's an emotional appeal, I think, for some people. They've had a physician for many, many years,
Right.
and it's like any other possible loss
Yes.
to deal with. But if you're bringing them in gradually and with your passion, I can see where people would want to gradually.
Right, and for people who are, concerned about that or feel like they have an attachment to their own physician,
Yeah.
we would pay for those physician visits a couple times a year to maintain that
Okay.
relationship
Okay.
if that was really important for people.
Okay. So that would be part of the assessment too then. I mean, it really is all grist for the mill, so to speak.
This is something that we would discuss with them on intake
Right.
and
Right.
work out those
Yeah.
decisions.
And in terms of payment, you said no copay.
Right. So
Okay.
we're the insurance,
Right.
and Fallon Health, who offers Summit Elder Care where we work,
Right.
is receiving capitated payment amounts from Medicare and Medicaid.
Okay.
So the person might have Medicare and Mass Health, but those are sort of in the background because we become the primary insurance.
Okay. All right.
And once that happens, they don't have a premium. They don't have to pay anything. We're taking
Okay.
care of it all.
Okay. So taking care of it all, that includes hospice should they need it someday?
Absolutely. So one of the principles of the program is we want people to join us and to be with us until their last days. We want them to transition with us.
Right.
The team knows them, and when the really important time comes for them to pass away, the team needs to be there and wants to be there for them and their family.
right.
So we offer hospice level services. Hospice is a particular option for Medicare as well. So people could leave Summit and join hospice. I don't really know of anyone who has, because they would prefer to stay with us, and we can
Right.
offer the same or similar services.
Right.
And including home services, the physician monitoring, nurses to come out to the home. The only thing we don't offer in our program specifically is the clergy, but we can certainly work with someone to help connect them with their own clergy
Sure.
at those times.
Sure. Well, if they're at home, if they're still living at home, they may belong to a church or a synagogue or
Right.
something,
Right.
so
And
they
and-
might make use of that.
Absolutely, and we would coordinate with,
Sure,
with their own
sure.
church or synagogue.
Sure.
And then there's an opportunity in hospice for 1 year of counseling after death of a spouse for the family. And we don't offer that specifically through P.A.C.E., but we can certainly connect people for other services to offer that counseling if that was necessary. So those are a couple small differences, but in the grand scheme of things, we offer
Right.
similar services
Right.
for someone who's in that end of life period.
Right. It does sound like this, you mentioned earlier about the growing population of elders, of which I'm technically one, but basically, this really is probably going to be the wave of the future.
For financial reasons, as well as the reasons that many people don't want to live in a nursing home.
Right.
It might be necessary for some, but for many, they would much prefer to stay at home. And we want them to stay at home. It's
Right.
much less expensive
Right.
to be able to provide that service, and that's really much better for the person as well, to feel like they have that connection to their space.
Right.
And it's really seen as a great option by all of the other stakeholders as well. So the state would like to see, the state of Massachusetts would like to see PACE programs continue to grow.
Okay.
Because they know we're doing a good service and it's cost effective for folks to stay at home and for us to prevent hospitalization and prevent the nursing home stays.
Yeah, one of the benefits of being in the PACE program with having all these people and all these experts really paying attention to you is making the interventions and offering the services to prevent the falls, prevent the infections that lead to being in the ER and lead to being in the hospital. And if we can keep people out of the ER, out of the hospital, not falling, we can keep them healthier much longer in the community. And what we know statistically is that people on PACE generally avoid the nursing home for 2 years as opposed to people who aren't on PACE. So we're able to keep people in the community on average about 2 years longer.
Okay, so there's ongoing research.
Oh yes.
The ongoing research with this. That's excellent because you're going to be able to trace and track.
Right.
Okay,
Yeah.
all right.
Yeah, and certainly, just to clarify, we do have about 12% of our participants in the nursing home.
Okay.
We actively work to maintain people in the community, and that's really our mission.
Sure.
But for some people, there might be a death of a spouse, the loss of a caregiver, the level of disease progresses to the point where they really need 24-hour care, and at that point we would place, and again, it's the PACE program would pay for the nursing home stay.
Okay. Things happen. People are going to decline gradually at some point, but the longer they're at home, the better is it going to be their psychological well-being.
Absolutely, yeah.
Right.
You know?
And that's typically, an older person's goal, to stay at home.
Sure.
And we're the sort of the best chance at staying in the community. That's how I like to describe PACE. For that family that's saying, we're committed to keeping mom or dad at home, whatever it takes, we fit perfectly with them and with their loved one.
Right. So what brought you both? You both have extensive experience working with this population, but what got you interested in working in gerontology? I'm interested in. I'm always interested in that.
Yeah, so I was the director for a 4-hospital system in upstate New York, director of geriatrics, and I had done a lot of research projects, a lot of different plan models, care plan models, geriatric consults, combining teaching medical students and social work students. But from a practical point of view, I was feeling frustrated with my patient care, and what I really enjoyed was the team-based care that I had in the assisted living facilities, and I wanted to do more of that, and PACE really provided that team-based care where everyone's really working together and maintaining people in the community, which is really important to the person, and makes me feel much better than just doing nursing home work. I obviously still have a little bit of nursing home work, and we have people who go to the hospital because of a necessary infection or trauma from a fall. Although we try to prevent it, it sometimes happens. And then we might have them in the nursing home for rehab, so I'll see them there. And so I follow them through the whole cycle. I'll talk to the hospital, I might visit them in the hospital, I see them in the nursing home, I follow them to the home, and so I get to maintain contact with my patients the whole time, and that's really meaningful to me, and that's kind of why I switched.
Yeah. Wow.
For me, so I'm a social worker like you, Lucille, and when I was in social work school, I thought I was going to work with young people with eating disorders.
90% of the students that enter the programs think they're going to work with youngsters.
Yeah.
Yes, it's true. It's true.
Yeah, I thought I had found my niche, and I did an internship on that, and but then I picked up a little part-time job working for a court-appointed guardian. So this woman who was working with clients, as we call them, who didn't have family members to help them make decisions. So they were appointed a guardian by the courts. And I was seeing some of her clients, and I kind of fell in love with them. And I said, I'll take more, I'll go see them all for you. I'll go visit them all. I'm connecting with them. I feel like I'm helping them with things.
Right.
Yeah.
And then once I obtained my master's degree, she said, just make a business card. So I did, and I began receiving my own court-appointed clients.
Okay.
And I worked with a lot of folks who actually didn't have family members available to them, or they were across the country. And I even found folks that had been placed in nursing homes who didn't need to be there. Oftentimes it's kind of like, it was like a, they bounced into the hospital because something happened, and then they bounced to a rehab facility, and then they ended up there long term.
Yeah, well, there was also deinstitutionalization.
Yeah.
And some of them ended. I used to do the PASSARs.
Yeah, yeah.
So, yeah. Yeah. So,
Yeah, so those folks, at the time that I was realizing, geez, I have a group of people living in nursing homes and they don't have an apartment in the community anymore, but they don't need to be in a nursing home.
Right.
I discovered P.A.C.E. And it wasn't Summit Elder Care, it was a couple of our colleagues, our other P.A.C.E. programs in Massachusetts. And from there on out, if I had anybody in a nursing home that didn't need to be there and they lived in the service area of a P.A.C.E. program, I got them onto P.A.C.E. and I moved them out of the nursing home.
Okay.
So it's interesting, that was way before I knew of Fallon Health and Summit Elder Care, our P.A.C.E. program. And I feel like I've come full circle because, way back then I thought that P.A.C.E. was the best option out there. And now I'm honored to be running a building for P.A.C.E.
Yeah. Well, and it's in your heart to work with the elder population.
Right.
It really does grow on you. It really
does.
Yeah.
And I think you noted this. One of the things that I'm most happy about is that all my colleagues are really passionate about working with older adults. And this is really meaningful work for us to allow people to maintain their safety and independence in the community for as long as possible.
Right. We're going to be winding down shortly. We've covered a lot of territory, actually, in the short time we've been here. Is there anything that you think maybe we've overlooked in a way?
What I would say in summary is just for anyone who's concerned about their ability to maintain their independence, for yourself or a loved one, a parent, to check out P.A.C.E. I think it's a good opportunity. I think it's key to do it before there's a crisis. You don't want to wait until there's an emergency.
Right.
Looking at opportunities ahead of time and seeing if P.A.C.E. Is a reasonable opportunity for you. And again, do it before there's an emergency or a crisis.
Right, being proactive, sure.
Right.
Well, a lot of us kind of wait till there's a crisis. Some people don't do their healthcare proxies until they're in the hospital.
Right.
But the whole thing is, but I can see where if they enter your program, that would be an upfront discussion. Just like when they come into a nursing home, it's an upfront discussion.
Right.
That's a lot of what we do is proactive discussions to make sure we keep them as safe and as high quality of life as possible.
Okay. Anything you think maybe we've overlooked?
I would just say that we're right down the street. We're,
You're
as
in
you
Lowell?
mentioned, we're on the campus of Duville, and you can come and see us. We're open Monday through Friday, so really our doors are open. We're a resource in the community, and we want folks to feel like they can stop in and learn more.
Okay.
Or they could check out the website, of course, but we're right here and we're here to help and to answer questions.
Right, and there are websites. You sent me some ideas for websites that people can look into. I just want to thank you both for coming, and thank you for watching.
Thank you so
you.
much, Lucille.
Okay.
For the Young at Heart is sponsored by Duville Life and Wellness Community, a commitment to care, a legacy of compassion. This is Duville.